This is something you really don't learn a lot about. It's called like a Bezoar. And what can happen when you have these cases, and I'll give you a case that I had that was horrible. This is an individual, a young lady who's had multiple attempts to harm herself. And when there's attempts to harm herself, they've been unsuccessful. This time she took a whole bunch of pills, massive amount of pills. So what forms is a Bezoar. So basically, you have this huge massive collection of pills. Usually it's going to be in the stomach, and it sits there. So when you think about it, the only areas that are going to be able to be affected are the outside areas, because it's formed, we'll call it like almost like an abscess just sitting there. These pills kind of glued themselves together. And the only metabolically active portion is going to be in the outside of the pills. And so what happens is the person initially, they took all these pills and they were sleepy, they were intubated, they got better, the tube was removed, then the Bezoar broke. And then, so think about when you're surface like this, when you're only having metabolism on the outside of these pills, the active ingredient of these pills is being broken down. But when it breaks, then you have all the surface area and all these pills, and you have a huge change and a huge shift. And on this young lady, unfortunately, once she was extubated, all these pills broke loose, and then she ended up passing from severe hypotension. She took a combination of metformin. She took bupropion. She also took a combination of calcium channel blockers and beta blockers. It was too much, so we could not help her out. So when you have a Bezoar, this collection of pills, what's the real thing they can use is see if your GI department will be able to stick a scope on it. Maybe they can pull those pills out for you. Now, there is kind of old wives' tales of taking, pouring Coca-Cola brand or cola product in there, and that will break up the Bezoar. Here again, as you run that risk with doing something like this, is you're breaking up and you're going to have the toxic effects of these medications could be exposed, and you can have a violent outcome from this. The best would be is if you can get your friendly neighborhood GI doctor to put a scope down there and pull them out. All right, here we go again with a question. All right, which of the following findings is most specific for the diagnosis of paratonsillar abscess? Another board review question. I will tell you this one's unfair. This is not a fair question, but this is something you'll find. Not a fair question. So let's go with here bilateral tonsillar erythema, and then we'll go for this cervical lymphadenopathy, trismus, generalized pharyngeal erythema, posterior pharyngeal wall bulge. So what is the question here? This is a 25-year-old man, presents in emergency department with a 3-day history of worsening sore throat, fever, difficult swallowing, and a muffled voice. He reports pain radiating down to his left ear, so left ear with difficulty in opening his mouth. On examination, the patient has a fever of 38.7. Oral pharyngeal exam reveals a left-sided paratonsillar swelling with deviation of the uvula to the right. He is unable to fully open his mouth. This is trismus. Which of the following findings is most specific in the diagnosis of paratonsillar abscess? Paratonsillar abscess. So why is this in the ICU section? Because guess what? In the ICU, they have to deal with airways. And if you have this huge paratonsillar abscess, it makes it very difficult to protect the airway. Remember, you can have the best lungs in the world, best heart in the world, but if you can't get oxygen through that tube from your mouth down, bad things are going to happen. So we're going to say right now, this is an unfair question. You have to know a very specific fact for it. So how do you work through this? How can you work through a question like this? You can only do the best you can. Is you have to look at what the possible answer choices are and try to eliminate what you can. What is the most specific findings for paratonsillar abscess? And we're going to give you the answer right here. It's trismus. I know this is not a fair question, okay? But this is most specific, okay? So you can have, your tonsils can be inflamed for multiple reasons. You can have cervical lymphadenopathy from multiple reasons, including GI cancer. You can have generalized pharyngeal edema from multiple, and you can have posterior pharyngeal wall. But trismus is very specific, is the inability to open the mouth fully, is this highly specific sign for paratonsillar abscess, reflecting the involvement of the pterygoid muscle due to deep space infection. Other findings can be a hot potato voice. What is a hot potato voice? It's a thick, muffled voice, like you have a potato in your mouth. Why would you have a potato in your mouth? I haven't figured this out yet. It's why people have potatoes in their mouth, but these are one of life's mysteries. But this is a thick, muffled potato in the mouth, speech quality, classic signs of a pharyngeal paratonsillar abscess. There's uveal deviation and severe difficulty swallowing, but trismus is most particularly predictive, and this helps distinguish peritonsil abscess from uncomplicated pharyngitis or tonsillitis. Here's an example of this. So how do you treat this? Well, this is where you hope to do what? You hope to get your friendly neighborhood ENT doc in there, and they guess what they do? Sounds pretty barbaric, but they stick a needle in there and they help drain it out. Depending on how big it is, but the most important thing is airway. Can you imagine trying to get an ET tube in that? Be pretty difficult. This one isn't as bad. What if they have bilateral, and be very difficult if you had to intubate this patient. So this is where you want to get your friendly ENT doctor who will help you with the airway, at least if they need to, but also too is to help you get this patient to probably help drain this. They may need to do it in the OR. And what they usually aspirate is a large bore needle and just drain it out. You would think that the patient has severe pain. They can localize and put a local anesthetic on there, and actually the patients will feel relief once they get in the abscess drained. Here's another example of, you can see in here, this is a pharyngeal, right here, you can kind of see this area and the crowding. You can see the airway is crowded here. Here's your airway, crowded and pushed over. That's another example of it. So what's the treatment going to be for this? Why are we talking about this here when we're discussing ICU? Because we're talking about airway management. Very important fact in ICU management. Peritonsillar abscesses are located with a collection of pus in the peritonsillar space between the tonsil capsule and the superior constrictor muscles. This space is composed of loose connective tissue, highly susceptible to abscess formation following infection. The management is going to be drainage and then IV antibiotic solutions. Ampicillin sulbactam is 3 grams every 6 hours. Clindamycin can be used. Other antibiotics could be ceftriaxone plus metronidazole or piperacillin tazobactam. These are other things that be considered. If you consider that this patient is susceptible for MRSA or has a risk for MRSA or known MRSA infection, we would consider putting vancomycin on. All right, so we have next is we have an unknown male found outside in the winter with altered mental status with a core temperature of 28. And let's give the social incorrect thing. What are we going to call this person? It's a bumpsicle. Okay, that's socially incorrect. We don't want to say that, but we did say it. Okay, so how are we going to check the temperature? Are we going to use symptomatic? The symptomatic's not going to work well. We can consider what? We can give a Foley temp probe. The Foley temp probe, you have to look at the various manufacturers, but you have to produce a certain amount of urine for this to work. We're not producing urine. The Foley temp probe doesn't work properly. You can consider esophageal probe. One thing against esophageal probe is that some of your imaging, the radiologist may throw off the imaging for the radiologist, so you may need to discuss with them first. There's another option would be is getting a core temp. That's probably the most accurate and best way is rectally. Rectally would be the best answer for this patient as far as getting their core temp. Hypothermia is going to be mild. It's going to be from 32 to 35 degrees Celsius, and the way of treatment is going to be passive external rewarming. Moderate is going to be 28 to 32. We have decreased shivering. You need to have activated external warming. And then less than 28 is coma, is active internal warming. So how do we do this? Active internal warming is you use a fluid rewarmer and you give them fluids. You can also, assuming that this patient is going to be probably intubated, you can use rewarming on some ventilators. You can use putting warm fluids down your OG or NG tube. You can actually put rewarming fluids through the bladder and pour warm, sterile fluids through the bladder to help rewarm. Passive external can be just changing, putting blankets on, and then you can also use warming blankets for these. You have to watch in the warming blankets, especially if somebody is severely cold, is that you can warm the surface, but it can cause problems with the core. That's why active internal warming is going to be one of your best for people who are severely cold. Hypothermia, see, is when you can use ECMO is recommended in those in cardiac arrest and hypothermia because it maximizes the rewarming rate, can allow for hemodynamic support. Normal treatment of ventricular arrhythmias and asystole during hypothermia is ineffective until the temperature is greater than 30 degrees Celsius. which is going to be 86 degrees Fahrenheit. Aggressive rewarming, inappropriate in all patients, suggestive of clinical situation in absence of obvious irreversible signs of death. So they need to be warm and dead. This is what you can see. This is an Osborne wave. Ozzy Osbourne has passed, but his wave continues. What is that? Is an Osborne wave is known as a J wave. See this J right here? Kind of a bad looking J. It's something I would draw. Horrible looking J. It is a positive deflection at the junction between the QRS complex and the ST segment. The wave is typically resolves when the patient is rewarmed. It's due to the outward potassium current in the epicardial cell noted when patient is hypothermic. Now let's talk about encephalopathy. If you don't know, always give thiamine to prevent Wernicke's encephalopathy and dextrose for hypoglycemia unless the diagnosis can be rapidly excluded. You have to make sure you give the thiamine before you give the dextrose. Always get what? So this is a patient encephalopathy. Get your acetaminophen levels, your salicylate levels, get an EKG and QRS. So you want to get your QRS and your QTC. What if there's a prolonged QRS, a prolonged or widened QRS? What do we can consider? Is consider TCAs. Also want to get a pregnancy test, urine serum toxic screening, finger stick blood glucose, and then you want to consult your friendly neighborhood poison control toxicologist to assist in management, just like you would have a CT surgeon assist you in getting a CABG. These are important parts of the team. All right, let's go with another unfair question. We're going to say every board question is going to be unfair, right? Because they're not fair. Which of the following is the most appropriate next step? We're doing a lot of next steps, aren't we? A lot of next steps. Initiate external cooling and give IV ibuprofen. Administer IV bromocriptine. Remember, bromocriptine can be used for also multiple things, but it also can be used for what? For diabetes treatment and continued surgery under total intravenous anesthesia. So we're doing surgery, it looks like here. Administer dantrolene and discontinue triggering agents, hyperventilate. Giving IV calcium gluconate. We've seen calcium gluconate and bicarbonate in a lot of these answer chains. Consider volatile anesthetic at lower rates. Administer amiodarone and place on active rewarming. Okay, so what do we got here? 24-year-old, so shouldn't have many medical problems. Undergoes elective laparoscopic hernia repair 10 minutes after induction of seroflurine and succinylcholine. His end-tidal CO2 rises from 35 to 65. So it's a big change, despite increased minute ventilation. So what are they saying with that? So our CO2 has increased despite having increased minute ventilation. So this is going to be something that's more of a metabolic process here. So we're blowing off the CO2, but something is going on. He develops rigidity, sinus tachycardia, and a core temp that increases, this is the scary part, to 39.5. Arterial blood gas shows an acidosis. This is a metabolic acidosis. Look at this. Metabolic acidosis and a respiratory acidosis too. So you have a concurrent metabolic and respiratory acidosis. Serum potassium 6.3. This is not good. This is not good. This patient is undergoing elective laparoscopic hernia repair, and this patient is at risk for death right now. Is at risk for death. So they're coming in for an elective procedure and at risk for death. This is a bad thing. So what are we going to do? We're going to administer dantrolene and discontinue triggering agents. Hyperventilate. So rationale. What is this patient having? Malignant hypothermia. Malignant hypothermia. And we'll talk more about this. He's been exposed to a volatile anesthetic and succinylcholine, and immediate management is cessation. We stop what we're doing, okay, and we give dantrolene. We give dantrolene, we oxygenate, and we actively cool this patient in treatment of complications like hyperkalemia and rhabdomyolysis that can happen. If we had a CK in this patient, the CK would be elevated. Malignant hypothermia, where you're going to have a respiratory acidosis with an end-tidal CO2 greater than 55, PCO2 greater than 60. Cardiac, you're going to have unexplained sinus tachycardia. You can have VTAC and VFib. You're going to have a metabolic acidosis with a lower pH. You're going to have muscle rigidity, especially the masseter muscle rigidity. And this can be from the succinylcholine. You can have muscle breakdown with an elevated CK. You can have your temperature rapidly increasing to 38.8. So you have a hypermetabolic response to a potential volatile anesthetic gas, such as halothurine, sevoflurane, and a depolarizing agent, succinylcholine. This is a genetic abnormality. It can be as high as 1 in 300. All right, so what's the treatment? Rapid reversal with dantrolene, supportive care. And you want to look at the family history because it could be autosomal dominant. You may want to get testing so that other family members don't go through this. Malignant hypothermia treatment, stop the agent as we stated, increase medical ventilation to lower the end-tidal CO2. Dantrolene, give 2.5 kilograms initial dose. Cooling measures. Treat arrhythmias, but do not use calcium channel blockers. Do not use dantrolene with calcium channel blockers. The combination may result in cardiovascular collapse. So remember, first do no harm. First do no harm. We don't want to use a calcium channel blocker with dantrolene. Coagulation profile, Q6 hours. We have to worry about DIC. And we want to treat the electrolyte abnormalities. Remember, there's a risk for hyperkalemia. And get patient and family. You get testing. You need to see if other members of the family can possibly have this. Neuroleptic malignant syndrome. What is this? Idiosyncratic reaction to medications with dopamine receptor antagonists. So these, you can get confused between these two. So we're going to go back. Malignant hypothermia can also be confused by what? Confused with neuroleptic malignant syndrome. These are different medications inducing. Let's go back. Malignant hypothermia. We'll do a fancy underline so will help us remember. Malignant hypothermia. These are going to be in surgery. Malignant hypothermia in surgery. In surgery. Neuroleptic malignant syndrome is more likely going to occur when they're getting a medication out of surgery. Out of surgery. This is a reaction to medications with dopamine receptor antagonists and rapid withdrawal of dopaminergic medications. So giving them and taking them away can cause this. They can develop, symptoms can develop over 1 to 3 days from the induction of this medication. The distinct features are what? Muscle fever, muscle rigidity, mental status changes, and autonomic rigidity. Major criteria all are required. They're getting exposure to a dopamine blocking agent, severe muscle rigidity and fever. Other criteria, at least 2, diaphoresis, dysphagia, tremor, incontinence, altered lack of consciousness, mutism, tachycardia, elevated or labile BP, leukocytosis, elevated creatinine phosphokinase. Now, what's the supportive care? Can use supportive care using a benzodiazepine, such as lorazepam. You can also use bromocriptine on these. Amantadine can be used, and dantrolene can be used on these. Remember, do not combine dantrolene with calcium channel blocker. Now, some patients can present 7 to 10 days following the drug exposure. In fact, they'll say more patients can present that way. So remember, let's do this again, is going back, malignant hypothermia and surgery, and then neuroleptic malignant syndrome. We're going to say this more likely out of surgery and exposure to dopamine receptor antagonists or rapid withdrawal of dopaminergic agent medications. And we'll talk about this. All right, let's talk about lactate and thiamine. And this can be used for treatment of refractory lactic acidosis with high-dose thiamine. You can look at this study. Remember, now, lactate is not going to cause your body to explode. We can run you up a flight of stairs, and guess what? Your lactate is going to increase. You won't die. You may feel you're going to die, but you're not going to die. So lactate is used to convert. So I want you to think it's pyruvate and lactate, pyruvate and lactate. And so pyruvate to acetyl-CoA. Remember these horrible things we had to memorize? Converting pyruvate to acetyl-CoA requires thiamine. So pyruvate and lactate convert to each other. So then pyruvate to acetyl-CoA requires thiamine. So if you have high doses of thiamine, it can reduce our serum lactate levels. Most cases of thiamine deficiencies are seen in critically ill patients. We're talking about lactate, we're talking the critical care session. This can be seen as these patients are going to have a thiamine deficiency, either because the fact is they had a deficiency coming in, or they use more thiamine because they're metabolically in distress, or they're getting poor nutrition. It can be seen in people who unfortunately have an alcohol use disorder, or patients with a history of bowel resection. This dosing in this study was 500 milligrams TID that can be used. You can also see people getting doses of 100 milligrams daily. There's not going to be any studies on this. People theorize the 500 milligrams TID is better because it's going to get into the brain and pass the blood-brain barrier better. Thiamine is water-soluble vitamin, so we're not going to have to worry about toxicity. It doesn't cost that much. It's a pivotal role in carbohydrate metabolism. Thiamine deficiency may be evident with any type of malnutrition, in which, because our body only stores about 2 to 3 weeks of thiamine. So what would be some examples of people that could have low storage of thiamine? Would be people who have an unhealthy alcohol use disorder, bariatric surgery, where they're not going to absorb it as well. And this is the one we're going to go to, is the hyperemesis gravidum. We're going to talk about how important this is and results in high morbidity and mortality if untreated. Low thiamine leads to increased provate and subsequently lactate. So we're going to take, remember, provate to lactate, then provate to acetyl-CoA requires thiamine. So low thiamine increases provate, and that converts over to lactate. All right, here we go. We're going to get a little speech right here. Saving 2 lives. Saving 2 lives with simple thiamine. We think about thiamine and deficiency in patients who are living in the street, malnourished. What about the patient with hyperemesis gravidum? This is a common condition requiring hospital care for women during the first 20 weeks of pregnancy. Can lead to malnutrition, volume depletion, and vitamin deficiencies. One of these can be thiamine. Just think about just giving a simple vitamin such as thiamine can save 2 lives, can save the mother and can save the baby. And I know you say, well, I don't really take care of pregnant patients, but you may. You don't, but you do, okay? And you may have an OB doctor on board and help taking care of them, but this is your chance to help 2 lives and save 2 lives with a simple medication, thiamine, which is dirt cheap, which really doesn't have any side effects. In these patients, they have prolonged nausea and vomiting and poor oral intake and hyperemesis gravidum. So think about this, lock this in your memory, teach this to your students and your learners, so that way you can save lives and lives can be saved in the future. Very simple.